A 39-year-old patient presents with a subacute, progressive cough and shortness of breath. The initial chest radiograph is normal. I am showing you an axial chest CT scan. Describe the findings.
The axial chest CT scan demonstrates extensive, bilateral, symmetric ground glass attenuation, predominantly in a central, perihilar distribution and sparing the subpleural lung. There are also several thin-walled, air-filled cysts of varying sizes in the upper lobes. The intervening lung parenchyma between the ground glass areas shows no significant architectural distortion.
Based on these imaging findings, what is your primary diagnosis and the clinical significance of the normal radiograph?
The primary diagnosis is pneumocystis jirovecii pneumonia, or PJP. A normal chest radiograph is seen in 10 to 15% of symptomatic cases, so a normal radiograph does not exclude this infection.
If I tell you the patient is HIV positive and has a CD4 count of 95 cells per microliter, how does this support the diagnosis?
A CD4 count below 200 cells per microliter is the critical susceptibility threshold for opportunistic infections. At 95, the patient is at extremely high risk for PJP and should have been on daily trimethoprim sulfamethoxazole prophylaxis.
What does the ground glass attenuation on CT represent pathologically?
Pathologically, the ground glass attenuation corresponds to intraalveolar foamy exudate containing the trophic and cystic forms of the organism, combined with fluid and cellular debris.
Describe the morphology and typical distribution of the cysts seen in PJP.
The cysts, or pneumatocysts, are thin-walled, air-filled, and demonstrate an upper lobe predominance with varying sizes and wall thicknesses, occurring in up to 1/3 of PJP patients.
What is the primary first-line medical treatment for PJP?
The primary first-line treatment is high-dose trimethoprim sulfamethoxazole, administered for a course of 21 days.
What is the major clinical safety warning when initiating antimicrobial therapy, and how is it managed?
The safety warning is that antimicrobial lysis of the organisms triggers a severe, acute inflammatory response in the lungs, which can cause significant respiratory deterioration. This is managed by administering adjuvant systemic corticosteroids.
State the specific arterial blood gas criteria for administering adjuvant corticosteroids in PJP.
Corticosteroids are indicated if the patient has a room air partial pressure of oxygen below 70 millimeters of mercury, or an alveolar arterial oxygen gradient of 35 millimeters of mercury or greater.
What is a common pleural complication of the upper lobe cysts in PJP?
A common pleural complication is spontaneous pneumothorax due to cyst rupture, which can be bilateral, recurrent, and difficult to manage, often requiring chest tube insertion or chemical pleurodses.
How is a definitive microbiological diagnosis of PJP established?
Definitive diagnosis is established by demonstrating the organism in induced sputum or bronchoalveolar lavage fluid using Grokat's methenamine silver staining or direct immunofluorescence assay. I would recommend immediate arterial blood gas analysis, initiating high-dose cotrimexazole and steroids, and consulting pulmonology. Refer to infectious diseases.